The enemies we fight against do not slow down. Cancer is relentless. Diabetes is relentless. Time is relentless. So we are relentless. We lose sleep at night dreaming of solutions for wearable technologies, remote monitoring, advancements, innovations, any weapon to win the fight. We are the men and women of Ochsner, and we are relentless. We're doctors and nurses and dreamers and healers, but above all, fighters. Yes, fighters.
Keep working it.
Because when it comes to your health, good is never good enough. So we do not slow down. Ochsner, innovating healthcare.
When Rose first started with us, she was just coming out of the hospital.
It's been a better situation. I can always depend upon her to help me. I'm home, and that makes me happy.
We're here to get her back into her routine and be able to live the life she wants to live. It's an honor to be trusted with that responsibility.
Hi, I'm Tom Bagwell, and welcome to Hello Health, a partnership with WLAE, the Ochsner Health System, and Humana to bring Ochsner's Hello Health weekly education and information series to television. Tonight we're going to be talking about robot-assisted total knee replacement surgery. When is it time to say out with the old and in with the new? Our guest is orthopedic surgeon George Chimento. In the second half hour of our program, we'll be taking your questions live by phone at 504-866-3200. That's 504-866-3200. If you've ever wanted to call this program, tonight would be the night, because we have a program note we'll be sharing with you a little later. But we'll also be taking questions tonight by email at hhquestions@wlae.com. Well, Dr. Chimento received his undergraduate degree from Providence College in Rhode Island. His medical degree is from the Georgetown School of Medicine in Washington, D.C. He did his internship at Tulane School of Medicine, also did his residency there. He completed his fellowship at the Hospital for Special Surgery at Cornell University. Dr. Chimento is certified by the American Board of Orthopedic Surgery, and he is currently chair of orthopedic surgery at Ochsner. And we welcome back to the program Dr. George Chimento. Good to have you back with us.
Good to be back.
I think
Thank you.
your fourth visit, so this would make you the most frequent guest of this program.
That's a very interesting fact, something I'm proud of.
Well, I don't know if you're happy to be back, but we're very happy that you're back. Always bring great education to the program.
It's good to be back.
Thanks. So you have a new position since you've been here last. Talk to me about what that entails at Ochsner and what extra work does that do?
Okay, well, I'm chairman of the department, so I still take care of patients and do surgery, but I'm also more in charge of the day-to-day running of the department as far as staff, working with administration, and recruiting new staff and faculty, which is the best part of the job.
Very good, very good. Well, tonight we're talking about total knee replacement surgery, and usually the cause of that is arthritis. So remind us, what is knee arthritis, and do we know what causes it?
Sure, there are several different types of arthritis, but the main type we'll be talking about tonight, and the most common type, is osteoarthritis, which is wear and tear type of arthritis. It's loss of the cartilage overlying the bone. And there's a genetic predisposition to that. There's some environmental factors such as repetitive trauma or obesity, which can contribute to it. And there's stages of it. From a very early stage, where only a single portion of the knee is involved, to a late stage, which involves the entire knee, and that's when people generally start thinking about having to have their knees replaced.
Well, you said there is a genetic component. Does that mean some of us, some of our knees will hold up longer than others?
Yes, and it does run in families to a degree.
Okay. And you said trauma. Are you talking about major trauma to the knee that's unexpected, or are you talking about things like bike riding, running, jogging, those sorts of things?
Not so much bike riding because it's low impact, but a major trauma can definitely contribute to arthritis in the knee.
Okay. I wouldn't imagine that everyone with knee arthritis needs a total knee replacement. So what are some of the other options?
Very good question. No, not everyone does not need a knee replacement that has arthritis. You can start off with activity modification and weight loss. As we discussed, obesity is one of the things that can predispose people to needing a knee replacement. There's medication that you can take, anti-inflammatory medication, over-the-counter acetaminophen. Those will definitely help. The use of a cane to unload the joint. Bracing, which can also help stabilize and unload the joint to a degree. Physical therapy can help reestablish strength and motion. That has a definite role in the treatment of arthritis. And finally, there's injections.
What do the statistics tell us about the number of people getting total knee replacements?
The number of people getting total knee replacements continues to increase. First off, nearly half of all adults will develop knee arthritis in their lifetime. That doesn't mean that half of all adults are going to get their knee replaced, but a half of all adults will develop arthritis in their lifetime. In 2010, there were 650,000 knee replacements performed in America, and that number is supposed to grow to 3.5 million by 2030, which is a significant increase. Women are predominantly affected. 63% of knee replacements are performed on women. And there was an interesting study looking at the economic benefit of performing knee replacement. And what they did was they looked at time spent in the hospital, going to the doctor, time lost from work. And by having your knee replaced, it actually is a benefit to society of about $12 billion overall. So a knee replacement, although it's the last resort, is a very good option.
Why are we replacing more knees? Are we living longer? Is the technology improved? Are insurance companies coming around? Or are employers coming around? Sometimes it's the employers who help decide what's covered and what's not.
I think a little bit of all of that. People are living longer because of increases in activity and the obesity epidemic. People are getting severe arthritis earlier in life. And people also know this technology is out there and they don't have to live in pain or not do a lot of the activities they like to do. So it's a combination of everything you mentioned.
Yeah, and in some cases, people who exercise too much wear and tear. In some cases, people who don't exercise enough with obesity, as you talked about.
Very good point.
On both ends of the spectrum. What's the recovery look like for someone with a total knee replacement? And what percentage of your patients, or any patients who have total knee replacement, will have some continued pain?
The general recovery after surgery, I guess the first month is considered the downtime where you're pretty sore and you're pretty stiff. But the recovery can last up to a year where you're getting stronger, the knee's feeling more natural. And, well over 90% of the replacements will last 12, 15 years or longer. But there are studies that show that up to 15% of people will have continued pain after a knee replacement, even if their motion is good, even if the components are well positioned on x-rays. So there's still this 15% of people that aren't doing quite as well as they would like and as we would like after the knee replacement.
Okay. Tonight we are talking about total knee replacement, but is there such thing as a partial knee replacement?
Yes, and I think probably discussed that on one of the previous shows. Mm-hmm. If it's an earlier stage of arthritis where only one portion of the knee is involved, and you can perform a partial knee replacement at that point.
Okay, but tonight, however, our focus is on total knee replacement.
Yes.
Is there new technology that's helping with some of the issues you're talking about, the alignment, and then obviously the getting rid of the pain or best you can?
Yes, we've combined two of our pre-existing technologies, which is the Mako robot, which is a device that we've been using for partial knees and for total hips for quite some time now, along with a total knee prosthesis that has a very good track record. So that's where the robotic-assisted total knee, how it came to be.
How are robots used to assist with the knee replacement surgery and other orthopedic surgeries, and have we seen improvement in that technology?
Yes, I believe this particular robot has been around for more than 10 years, and the software and the hardware and the equipment keeps getting refined to make it more user-friendly. It's been used for partial knee replacements for several years, total hips for several years, and the total knee aspect is relatively new for a year, maybe a little bit longer than that.
For people who may have heard about robotic surgery, the name we've heard, and not always in a positive fashion, the Da Vinci robot. But this is not the Da Vinci robot, and Da Vinci is not used in knee replacement, correct?
No, this is a Mako robot. It's a totally
Okay.
totally different device.
Very good. What's been your experience with robotic surgery at Ochsner?
Well, we started our robotic program at Ochsner, I believe, in 2013, in May of 2013, and we've done over 800 cases, 528 total hips, 285 partial knees. We got the total knee application maybe about 6 weeks ago or so, maybe a little bit longer than that, and we're getting more and more experience with the partial knees. We've in this region, we were the first hospital in Southeast Louisiana to actually have the robots. We're very experienced with using the robot.
So who performs the surgery, you or the robot?
It's a combination. There are 3 different ways you can use a robot in surgery. One is completely passive, where it's more like a navigation, where the surgeon does all the work and the robot just gives some visual feedback. And one is what they call an active robot, where the surgeon really doesn't play a role and the robot performs the surgery. And this device does exist, and it hasn't really worked the way we want it to. The Mako robot is a semi-active or haptic type of robot, and what that does, the surgeon is in control of the device, but the device gives feedback, either through visual cues or tactile cues, where the robot won't let you deviate from the plan. So the Mako is kind of the best of both worlds as far as that goes.
Just like the new car you can drive now, when you start to go out of the lane, the steering wheel starts to vibrate, or a light goes on, or something along those lines?
This is a little bit more than vibrating. It actually will stop and shut down if you're going to deviate too much from the plan. So it's very close to that, yes.
Is there part of the surgeon ego? I'm not talking about you specifically. It says, I can do this on my own. Why do I? And we've been doing it for years without the help of a robot.
Yeah, we have been, and we've been doing well. But to go back, we still have that 15%. So there's something that the robot, I think, makes us more reproducibly accurate, and there are several studies that have shown that.
Yeah, what do these studies show us about safety and effectiveness of the robot?
Well, specifically for the total knee, at our national meeting last year, there were 2 very good studies regarding the robotic total knee. One was they just compared a group of manual knee replacements to a group of robotically assisted total knee replacements, and when they looked at the results of both, they found out that the robotic surgery was a bit more accurate. And the other thing is, there's a lot of important structures. There's arteries, there's nerves, there's ligaments about the knee that the saw blade comes in very close proximity to. So they've done several studies to verify that the robot is safe and it's not going to allow you to cut any of these structures. So those are the 2 big studies that came out that proved the efficacy and the safety.
I would imagine to be able to perform, first of all, to become a surgeon, there's a certain level of training and all those other things, but there are probably some surgeons more skilled than others. Looking at those test results and look at the history, were they with the same person? So did they take a George Chimento who had been doing surgery without the robot for 5 years, and then George Chimento doing the surgery for 5 years with the robot, and compare the same surgeon? I think you know where I'm going.
Yes, the actual landmark study for this actually came out of Harvard. So you're talking about some of the most renowned total joint surgeons in America, and this was done with a total hip design, and what they found was that the surgeons were much more accurate, even if they've been doing it for years, by using the robot. And it reduces the amount of outliers. So if someone's moved a little bit on the table, you may not be able to appreciate that, but the robot can, and that 2 or 3 degrees can make a difference.
And it's a good point that we bring it up now. Patients they may move, but for some other reason. Patients are asleep during all this. They are sedated, correct?
Correct.
Okay. And just for the record, the doctor did go to Cornell, but this was a Harvard study, but you still accept the findings?
We still accept the
All
findings,
right, very
yes.
good. Having fun here tonight. What are the advantages, as you see them, for using a robot?
Well, there are several, but there are 3 main ones. It's increased accuracy, you can be more precise, which we've discussed, and you have the ability for real-time planning. And the advantage of having more accuracy is that you have better function. If the joint is aligned better, it works better. The implant will wear better, meaning if the alignment is proper, the forces are distributed equally across the implant, so part of it won't wear out sooner than it should. And potentially, with better function and better accuracy, you can have a quicker recovery. The jury's still out on that a little bit. By the precision, it's a minimal amount of bone loss, so you get to preserve bone, because it's good to keep as much of your own bone as you possibly can, obviously. So the precision allows us to remove just the minimal amount of bone we need to replace the joint. And also during the surgery, we get to plan and adjust based on the patient's individual anatomy. And these fine adjustments just make the joint feel more natural.
Positioning, alignment is important.
Correct.
What about the prosthesis itself, the materials you're using? Have we seen improvements in that area?
Well, what we were using in this is a prosthesis called the Triathlon, and it's a prosthesis made by Stryker, which is the company. I think I need to say that. And it's been in use for several years, since March of 2004. There's a 10 years follow-up on this, and I believe there's about a 90-95% survivorship of this particular implant. So the implant itself has very, very good results, and there's 2 million of them have been implanted worldwide. So you're taking a very reliable implant with a good track record, and you're marrying it to this technology, which allows you to be more precise and more accurate. And I think that's the main advantage of this.
Okay. Do you think there's a day coming that a total knee replacement will be the last knee? Because even at 12 to 15 years, it's possible that there would be a second knee replacement down the line for someone who's in their 50s or 60s, correct?
Yes. With some of the newer material that we have, I think you're going to find that number starts going out longer and longer. But right now, those studies don't exist. So the studies that we have say 90% at 12 to 15 years. But I think if in 10 years, if you're still doing this show, you may find that number is about 30 years or 35 years. That's what I think, but the science isn't there to say that definitely yet.
I hope we are doing the show, and I hope it does last that long. Get a little more precise and specific about how technology is helping, especially in the area of positioning.
Yes, so the first thing we do is we obtain, when we decide that the patient needs a knee replacement, we obtain a CT scan, and that CT scan gets formatted by the robot, the technician and the robot. And what you can do with that is you can plan very precisely the sizing and the position that you like, but this is just by looking at the bone. Once you get into the surgery, you can fine-tune this a little bit. You will release some tissue, you will try to balance the joint to correct any malalignment that exists, and you can fine-tune the positioning of the prosthesis at that time. And then once you're happy with that, you use the robot to prepare the bone. And what that is removing the amount of bone, exact amount of bone that you need. And it's accurate to about 1 millimeter or so it's pretty accurate. And that's where the haptic guidance comes in, that you can't deviate from the plan And once the bone is prepared, then we go on to the next step.
And these advances really are helping you even before the surgery starts, right?
Correct.
In what ways?
Well, you have a better idea of the size of the components. It can be more accurate than just the way we do it now, which is you will have x-rays and you'll plan it with a template, and in the time of surgery you will size the component. But with this, by being able to position it a couple degrees in flexion, or, well, not to get too technical, but by varying the position a degree or two either way, you can get the size much more precise, and that's something you can't do without the robotic assistance.
All right. And I think you brought another image to show us exactly how the robot is helping during surgery, right? A little more technical.
Yeah, the preoperative planning, like I said, that's the patient's own bone, and you can take implants of different sizes and vary the position, so you have a very good idea before you start what the sizes are and what the position will be. But patients also sometimes have ligament deformities where they're tight on one side or loose on the other side of their knee. So you can only get so much from the preoperative plan, but to have that much accuracy going in is incredibly helpful.
And let's see exactly what the robot is doing during surgery. Here's another image, Doctor.
So what this is, you can see the robot, which is the white and blue device there, and there's a camera, and there's also a screen. So the camera, at the time of surgery, we will put these tracking devices in the patient's bone, and I have a video at the end that we can
Great.
Look at with that. And the tracking device feeds into the camera, which feeds into the computer, which gives the information back to the robot, and that lets us see the alignment that we need, and also lets us know about the amount of bone to remove. And what we do, there's a probe, and once again we'll see this in the video, but we mark different points along the patient's bone, and that's how the computer confirms that the CT scan was accurate. So you have the CT scan preoperatively, but you also have the real-time feedback of probing the bone during the time of surgery, and that's how you confirm the accuracy.
Don't know how much interest you have in movie making, but it almost reminds me of where you're doing digitally things in the movies where they're tracking the actors, where they're going to come in later and add things with dots all over the body. Seeing that image reminds me of that.
It's similar.
Okay, terrific. How does the robot help with alignment of the new knee?
Well, once you have the sizing and you do what you're supposed to do in the surgery, which is release the ligaments and correct the deformity by releasing soft tissue, then you will what's called dynamic joint balancing. So you'll bring the joint through a range of motion, and you'll capture different poses with the knee out straight or with the knee in flexion, and you'll be able to see how tight or loose the joint is, and you will know whether you need to either remove a little bit more soft tissue, or you need to remove a little bit more bone, or if you need to adjust the component 1 degree this way or 1 degree that way. And you can fine tune it so the joint is balanced down to the millimeter, which is more accurate reproducibly than we can do without the robot.
Any fine tuning that needs to take place?
Well, yeah, that's what we just discussed. Once we've gotten the ligament balancing done and we know the sizes and the positioning, you once again bring the joint through a range of motion. If you need to tweak it a degree or so here, a degree or so there, a millimeter this way, a millimeter that way, you can do it. So
what happens next?
Well, once you're happy with this, the next thing you do is prepare the bone. And the video has some good shots of this where you will remove, with the help of the robot and a saw blade, you'll remove the millimeters of bone you need to remove in order to put the prosthesis in.
And how do you know you've hit the targets, and is there a final check?
Well, but one thing you can tell if you hit the targets is the green will disappear and it will turn white, and you can see that in the video. But once the bone cuts are made, there's a trial prosthesis that goes on. Not the actual, but a trial. And once that's on, you bring the knee through a range of motion and you capture those same poses in extension and flexion. And you can see how balanced the joint is, and if you need to adjust anything a millimeter or so one way or another, but so that would be the final check.
All right, we had 2 videos. We do have the better one.
Oh, very good.
So very good. Thanks to Anna, our director, and our crew tonight for getting that prepared here late. But the doctor's going to walk us through. It's about a 2-minute video, right?
Yes.
Go right ahead. Here we go.
I'd like to thank them for preparing the newer video too, because it kind of got delivered at the very last minute, so that was helpful. Thank you.
If you're a little queasy here, we'd ask you just to close your eyes. After all, it is a surgery, but that's okay. And we'll let you know when it's okay to look back. I think we've got that video ready to go now. Video of a total knee replacement surgery. Let's see if we have that now.
Good. So this is the CT scan of the patient's bone, and the green is are the trial components, or the laid on top of the bone. So that's how we get the sizing. So this is the patient's knee, and you can see those arrays out of the thigh and the shin bone, and that is how we help track the position. And I'm touching some other parts on the bone there with a probe to confirm the position of everything. We have checkpoints, and the checkpoints enable us to be sure that nothing moves during the surgery. And once the checkpoints are established, this is where what we call registering the bone, which is what you discussed with the several dots all around both the thigh bone, the femur, and the shin bone, the tibia. And this is a video here of me registering the bone to confirm that the CT scan is really what we're seeing here in real life, and that they match real well.
This video is about 2 minutes or so. How long does a total knee replacement? More than 2 minutes. How long does a total knee replacement surgery last?
Generally between 45 minutes to a little over an hour. Here we are. We're removing the bone. So, a way to look at this, it's almost like a video game. You can see what I'm looking at on the screen is the saw blade. And as the green goes away, that's the bone actually being cut. And the white is what you want to see. You want the green to go away, and you'd like to see white. If you see red, it means you've just moved a little bit more bone than you wanted to. It's not the end of the world. That's only a millimeter or so, and it won't let you take any more bone than a millimeter more than you're supposed to take. And that outline you see around the bone is... the robot won't let you move past that little green line there. So you can't go cut a ligament or an artery. I mean, here the bone is being removed from the shin bone or the tibia.
You know, I was asking you earlier about, there's a part of you that says, I've done it before, I've done it without this before, why do I need it now? Well, you can just see visually, it helps you become perfect in what you're doing. We're
still striving for perfection, but it helps. It's one step in the right direction, yes.
Very good. Our guest tonight is Dr. George Chimento. Tonight we're talking about robotic-assisted knee replacement surgery. I want to invite you to call us with your questions. And by the way, this is probably going to be the last night you're able to do that. We'll have a programming note at the end of tonight's program. Our phone number is 504-866-3200. That's 866-3200. Or you can send us questions by email. There's our email address, hhquestions@wlae.com. So, Doctor, let's recap. What was the major points you wanted to bring to our viewers this evening about total knee replacement surgery?
Well, I think obviously the total knee is a good operation. It's got a very good track record. It's been around for a long time. But there's a certain segment, about 10 to 15%, that even though the x-ray looks good, their motion is fine, they still have pain and the knee doesn't feel natural to them. And I believe the accuracy and the precision that the robot allows us to have, and the ability to make changes during the surgery by a millimeter here or a degree there, will allow us to give patients a longer lasting, more natural feeling knee replacement.
All right. I'm curious to know if there is still pain, is it possible to go back in for another surgery? I'll ask the doctor to hold off on that answer for just a moment because we're going to take a break, but we're ready to take your calls and emails. Our phone number again is 504-866-3200, 866-3200, or you can send us questions by email. There it is one more time, hhquestions@wlae.com. Again, we'll take a break. Be back in a moment. This is Hello Health on WLAE.
I love taking care of my mom. It wasn't easy at first. She learned how to better communicate her needs.
And you learned how to not ignore yours.
I discovered how to make healthier meals.
And I discovered how much I enjoyed them.
Becoming a caregiver is a learning experience for everyone. Find articles, tips, and tools from experts and others who have been in your place. The Caregiving Resource Center at aarp.org/caregiving.
And welcome back to Hello Health on WLAE. I'm Tom Bagwell. Good to have you with us. Tonight we're talking about robot-assisted total knee replacement. Our guest is Dr. George Chimento. Well, as we were heading to the break, I was posing the question, is it possible and is there ever a need to go back in and do some of that refining?
Well, generally, if there's a problem with the stability or the sizing, hopefully that won't happen, but there are occasions where you have to go back in afterward and make a correction, but thankfully that's the exception rather than the rule.
And in the cases of those 10 to 15%, and maybe that number's coming down with the help of the robot and new technological advances, there's really not a whole lot you can do just for the pain with another surgery, correct?
No, because you wouldn't know what you were correcting. And they've done studies that show to try to go back in and redo a knee without a diagnosis of what you're trying to fix doesn't really work that well.
All right. Let's go to our phone lines. Let's go to line 1. Mary, you're our first caller tonight. Mary's calling from Lafitte. Dr. Mary, welcome. You're on with Dr. George Chimento.
Hi, thank you for taking my call. My question is this: would there ever be a reason not to use the robotic surgery at this point in time?
Great question, Mary.
Very good question. Actually, yes. I think at this point, if there is a large amount of bone loss, or if someone's body size is a little too large, logistics of using the robot would be very difficult. And also, there is an additional cost associated with using the robot. So the way we approach this is we look at how the demands the patient are going to put on the knee, the activity level of the patient, and the age of the patient. And we discuss this with the patient. And honestly, some patients prefer not to use the robot. So we have the discussion basically with every patient to decide if the robotic approach is the correct approach for them.
Mary, terrific question. Thank you for asking it. Let's go to line 2 on the North Shore. Tom calling from Slidell. Welcome, Tom. You're on Hello Health.
Yes, I'm. Both of my knees are bone to bone, and so I know I need a replacement. But I'm 85 years old, relatively good health. But I know once you pass 80, that takes a long time to heal. Maybe I'm too old for that. Thank you, Doctor.
Well,
thank you, Tom.
Thank you. That's another question that comes up quite often. And once you hit the age of 80, there is an increased chance of having a complication, but we look at someone's overall health and not the age when we have the discussion with them whether or not they're a candidate for surgery. So if your only risk factor is you're over 80, you may be a better candidate than someone who's 65 with a long list of medical problems.
Would some of it also be and we don't know the answer, how active Tom would be? Does he still enjoy walking and going out, and would lifestyle be a part of it?
Quality of life is definitely an issue. So if he can't do any of the things that he likes to do, and he's in good health, that's the age is a number. It's not the limiting step.
All right. Tom, thank you for your call tonight. Let's go to line 3. Carl calling us from Kenner this evening. Carl, you're on with Dr. Chimento.
Thanks, doctor. I had my right knee replaced a year ago, April, and it was with one of the competitors, not Ochsner. And the unit that was placed in my right knee, total knee replacement, is the same unit that Dr. Ochsner uses. I met with Dr. Ochsner 3 weeks ago. But what they did in the first operation was they had something I think called iovera, which they froze the nerve on the left side and killed it, I guess, and it's supposed to grow back a millimeter a month, which the idea being to eliminate a lot of the pain other than just pain pills. Is there anything, what are your thoughts about that, and do you have anything similar to that you do to help the avoidance of just taking a bunch of pain pills?
Great questions tonight. Yes, actually, there's been some very good research by one of our colleagues at LSU who started using this procedure, and it seems to have a role in reducing postoperative pain. And I think it's something we've incorporated a little bit into our practice, and we are probably going to start doing more of it. Some studies show that it helps, some studies show that it doesn't, but the way I look at it, anything that can lessen the pain beforehand is definitely helpful.
Okay. Carl, thank you so much for your question tonight. Our phone number, by the way, there is at the bottom of your screen, 866-3200, 866-3200. Patricia is next on line 4, calling us from Norco. Patricia, you're on Hello Health. Patricia, go right ahead. You're next. Patricia, are you there? Having a tough time? Okay, it seems like we've lost Patricia. Patricia, Patricia, are you there?
Yes.
Oh, go right ahead.
Okay. She needs a knee replacement, and I want to know how many other doctors do this robot. I'm very impressed with it right now, but she has an appointment with another doctor at Ochsner that had done my knee replacements years ago. And but we impressed with what you said and would like to talk to you about it, or how many other doctors at Ochsner does this procedure that you do with the robot?
There's one of my partners, Dr. Mark Meyer, who actually appeared on the show with me the last time, does this also, and we've been doing this together since the start in 2013. I wanted to bring him along tonight, but they said they stopped doing the 2-doctor shows, so it's just me tonight. But Dr. Mark Meyer does this also.
And to your question about wanting to meet with the doctor, we have a number set up just for viewers of this program, and we'll be passing that number along to get a hold of Dr. Chimento or any of the doctors at Ochsner. We'll be doing that at the end of tonight's program, so we'd ask you to hang on for that. Let's go to line 5. George is calling us from New Orleans this evening. George, welcome. You're on Hello Health.
Yes, thank you, Doctor. I was x-rayed about 3 months ago and told by the doctor that I do need a knee replacement. I tore the cartilage on the inside part of my knee at work. And I do have some health issues. I have AFib, and I've had some other health issues. And the question I have is from a friend that had it done. He said rehab is the most important part after surgery, and I'd like to know how long you have to rehab a knee.
Everyone is a little bit different, but let's just say at least a month. And that can either be done at your house, or if you have a ride, we've been sending people directly to outpatient therapy, because personally I think it will hasten the recovery a little bit, although there really aren't many studies that confirm that, but anecdotally is what we've seen. But after that month, it varies. Occasionally, people just need the 4 weeks. Occasionally, people need longer. So let's just say somewhere between 4 and 8 weeks would be the norm.
But you said before the knee might feel exactly like it was before. That could take up to a year for some patients, right?
Yes, you won't need therapy that entire time, but you can feel yourself getting better, and the motion can improve slightly, and that can occur up to a year from the surgery. But if you really look at, most of the recovery is done within the first 6 weeks.
Okay. Again, our phone number 504-866-3200, 866-3200. Let's go to Joanne calling us from Hammond on the North Shore this evening. Joanne, welcome. You're on Hello Health with Dr. Chimento.
Thanks for taking my call. I had an accident. I was in an accident in 1992 and had to have pins and a plate put in my knee. I've had no problem with it since then, but I'm starting to get that arthritic pain, and I was wondering, would I have any problems, or would this robotic surgery be better for me, or can it be done on me with all this extra hardware?
Once again, a great question. It depends where the hardware is and how it's fixed. So potentially having the hardware in the right place will make you a perfect candidate for this, but if it requires removing a lot of hardware from your knee, that at this point I think is something that would probably be better done manually. As we get more experience with the robot, and I can speak with this from my experience with hip replacement with the robot, is initially you start off with the more straightforward cases, and the more you learn and the more facile you get with using the robot, you start expanding the indications. But I think at this point, at least in my hands, if it involves hardware removal, I would probably opt not to use the robot for that case.
Thank you very much, Joanne, for your call. Our phone number is 504-866-3200. We do have some phone lines open. Again, 504-866-3200. You can also send us emails, too, at hhquestions@wla.com. Some of you have already done that, and we will get to your emails here shortly. First, let's go to line one, though. Noah calling us from New Orleans this evening. Noah, you're on Hello Health. Good evening.
Thank you, and thank you for taking my calls.
You bet.
My wife has pain in both of her knees from arthritis, and she's been taking the steroid injections to take care of the pain, but she's been advised that she needs to have both knees replaced. And my question is, how often are both knees done at the same time?
That, once again, a great question. Not as often as they used to be. Historically, probably 15-20% of the knees we did were both knees at the same time. But studies have come out where there shows there is a little bit of a higher complication rate doing both knees at the same time than staging them. So the way I look at this right now, and I think most people feel the same way I do, that you have to have two very, very bad knees, and you have to be very, very healthy in order to have both knees done at the same time. Otherwise, it just makes more sense, and it's a little bit safer to have one done, recover from that, and then have the other one done.
You said, thank you very much, Noah, for your call. You said you've alluded to complications a couple of times this evening. What sorts of infection, what sort of, any surgeries a risk, right?
Yes, but with the having, we call it simultaneous bilateral knee replacements, when you do both knees at the same time, and it's usually heart and lung complications, pulmonary complications, issues with your heart that just seem to be more prevalent from having both knees done at the same time. It's kind of counterintuitive. It's actually a bit safer to have the two separate surgeries than the one big surgery.
All right. Good question, though, as the doctor pointed out. Let's go to line 2. Diana calling us from Metairie this evening. Diana, you're on with Dr. George Chimento.
Yes. Hey, Tom, and hey, Doc. Thank you so much for this wonderful show tonight. I was just calling. Do they require any kind of medication or pre-medication before dental treatment or a regular prophylaxis in a dental office?
Yes, actually we do. There's a little bit of a split between the orthopedic surgeons and the dentists, but the philosophy is the same. Everyone agrees that for about 2 years after the surgery, you need prophylaxis. After that, I think the American Dental Association says you don't need it anymore. The American Academy of Orthopedic Surgeons is on the fence about it, but at Ochsner, we believe that a total joint that gets infected is a catastrophic complication for the patient. It's a very, very hard thing to deal with. So in our minds, it's a lot simpler to take a few pills an hour before your dentist appointment than have to deal with an infection down the road.
All right. I believe that's Diane, who I know well, who's a regular viewer of this program and works in a dental office. So great question. I'm really glad you brought that up, Diane, and thank you for watching and for all your support. Let's go to line 1. Arthur is calling us this evening, as he's actually calling right now. Arthur, welcome. You're on Hello. Arthur, we're going to come back to you in 2 seconds. I do want to get to an email question first, so here we go. Doctor, I had a knee replacement in 2013, so about 5 years ago. I've never gotten relief, still very stiff, still very sensitive. Your knee is always very warm. Is there some kind of procedure similar to the robotic procedure that would give me my life back? So this is obviously impacting Sandra dramatically. Sandra, thank you for your question.
Unfortunately, robotically, no, not at this point. I think with your symptoms, you need to have an evaluation to be sure you don't have a low-grade infection, to be sure that's not the cause of why you're still having this discomfort that never seemed to have gotten better since the surgery. But if it does require another surgery, at this point, there's really not a place for robotic assistance, in that we're not at that point with the robot yet.
Okay. Thank you for your question, Sandra. Line 1, there's Arthur. Arthur, welcome. You're on Hello Health. Thank you for your patience. Arthur, go right ahead.
Hello. Hi, Doc. My name's Arthur. I had left knee surgery just about a year and 3 months ago. Is it natural that when you're walking from time to time, you'll have a clicking noise in your knee?
Actually, yes, it is. There's metal and plastic in your knee, and occasionally it will click, it will make a noise. Sometimes it can be quite loud, which is disconcerting, but as long as it's not painful, I wouldn't be that concerned about it.
What is the scar? Where is the cut, doctor? And what does the scar look like when it's all said and done?
We use a subcuticular closure. The cut is about that long, right on the front of your knee. And the way we close it, we used to use skin clips or staples. We've gotten away from that, and we use a subcuticular closure and a glue, which actually gives a much nicer scar and has actually stopped wounds from draining. So it works from both the cosmetic aspect and a functional aspect. So we have changed how we close the wounds.
All right. And what's over the wound and for how long, and showering and those sorts of things?
We use a silver impregnated dressing. It's like a big Band-Aid, but actually has silver on it that will help fight infection and bacteria. And we keep that on for a week to 2 weeks until we see people back for their first visit. So the wound will basically stay sterile from the time of surgery till that 2-week visit where the dressing comes off and the little suture ends get snipped out.
Diane brought up the question about going to the dentist's office for patients. Anything else we should know about? Any other care or special consideration that would have to take place?
Well, if you have a cold or a flu, you don't need to be concerned about that. But you do want to be sure if you have a bacterial infection elsewhere, you definitely want to seek prompt care for that, because you don't want bacteria to spread throughout your body and land on the prosthetic, the artificial joint, because the bacteria can get adherent to the metal and you can get an infection that way.
Okay, here's another email question, and a terrific one. Doctor, is there the complication rate for robotic surgery versus non-robotic surgery? Any statistics there to look at yet?
Yes, actually, when we talked about those arrays that we put on that allow us to track the knee in space, there's 2 drill holes in both the thigh bone and the shin bone, which doesn't exist in non-robotic surgery, and the risk for fracture is there. Thankfully, it's not something we've seen, but they've been reported elsewhere. We've never had an issue with the robot malfunctioning or breaking, although we discussed that with the patient when we talked to him about the surgery, because it is within the realm of possibility. But I guess for a complication specific to the robotic surgery, it would be probably from the pin sites.
All right. So with a $6 million man, and you're old enough to remember him, you went in and you built a brand new knee. So you've, right, he's actually a brand new person there with a brand new knee. Any limitations? If I was a biker before, can I be a biker again? If I was a runner before, can I be a runner again?
What I tell people is these aren't designed for very high impact activity. So you can bike, you can play doubles tennis, you can golf, you can ride a horse. If you want to jog around the block, you can probably do that. I don't think you should run a marathon on one. I just don't think they're designed for that type of impact. But for most activities, you can go back and do pretty much anything you'd like to do. And there actually are some surgeons who allow patients to have no activity limitations and just do whatever they want. But the way I look at it, I just don't think they're designed for a lot of high impact activity.
Okay. And one more question, doctor, another email question. Can you have a knee replacement while being extremely overweight? Would that disqualify someone for this surgery?
This is something else that's changed over time. When we went back and looked at the data as to who did well, who didn't do well, who had infection, who didn't get an infection, there's a number called body mass index, and it's how much you weigh kind of divided by how tall you are squared. And what we've come to learn from this is if the number is above 40, you have a higher incidence of having some sort of complication after a knee or a hip replacement. A lot of places use 40 as a strict cutoff. We're somewhere between 40 and 45, leaning towards 40. Because the idea is we don't want to deny care to anybody, but we want to get the best result we can. And if you have a complication like an infection, you're going to be 10 times worse than if you never even had the surgery. So we actually have a program where we help people lose weight prior to having the surgery.
Makes sense. And we do have one final caller, doctor. This is Joan calling us from Gretna. Joan, you're our final caller here on Hello Health in more ways than one. Go right ahead.
Yes, I had knee replacement on one leg 4 months ago today. I'm doing pretty well, but however, the knee is still swollen. Although it's gone down, I've gotten different versions on what to do about it. One is to keep my leg raised up on the couch above the edge of it, above my heart, and then to put ice pack on it simultaneously. Is that the best solution?
Just a quick follow-up. Is your knee swollen or is your leg swollen?
It's mostly the knee, although there's a little swelling around the ankles sometimes.
I think if you want to elevate it, that's fine. If you want to ice it, that's fine. I honestly think time will probably do more for this than anything else. And that's one of those things why we talked earlier about how you can get better for several months to a year after the surgery. And I suspect you should get better with time from that.
Thank you.
You're welcome.
Thank you, Joan, very much, and best of luck to you. And I want to thank Dr. Chimento for the education and information he's provided tonight and for his work in the Oxnard Health System. Always great to have you. We look forward to your 5th visit.
Well, we'll see when that happens.
All right.
Thank you.
Hopefully sooner than later. Well, to make an appointment with any of Oxnard's physicians, including tonight's guest, Dr. Chimento, or to register for any of Oxnard's Hello Health seminars, you can call Oxnard, a number set up just for viewers of this program. Here it is, 504-842-5669. That's 504-842-5669. As a reminder, you can rewatch tonight's presentation or most of our Hello Health programs on our website at WLAE.com or on Oxnard's website at oxnard.org. They've got lots of them there too. And we do have a program note to pass along tonight. Starting next month, we will be moving to a new studio in Benson Tower, our 3rd home since we started this program about 7 years ago. We'll be shortening the program from 1 hour to 30 minutes. Same knowledgeable and informative guests, just like tonight's guest, bringing you cutting-edge medical information straight to your living room. Our thanks again to tonight's guest. Thanks to Humana and Oxnard for making our program possible, and our crew here at the WLAE studio. A special thanks to them for all their many years of hard work. And as always, our final thanks is to you for your support of our program, Hello Health, and our station, WLAE. Good evening.
The enemies we fight against do not slow down. Cancer is relentless. Diabetes is relentless. Time is relentless. So we are relentless. We lose sleep at night dreaming of solutions for wearable technologies, remote monitoring, advancements, innovations, any weapon to win the fight. We are the men and women of Oxnard, and we are relentless. We're doctors and nurses and dreamers and healers, but above all, fighters. Yes, fighters.
Keep working it.
Because when it comes to your health, good is never good enough. So we do not slow down. Oxnard, innovating healthcare.
When Rose first started with us, she was just coming out of the hospital.
It's been a better situation. I can always depend upon her to help me. I'm home, and that makes me happy.
We're here to get her back into her routine and be able to live the life she wants to live. It's an honor to be trusted with that responsibility.